Welcome to Module 1 of OrthoEpidemiology, where we will be discussing the basics of scientific inquiry. The most important consideration for starting your research or for reading someone else's is the research question. What question are the researchers trying to answer with this project? One framework people use to sort this out is called the Pico model of question design. The question should address the population of interest. This will determine who the finding of the research pertains to. Second, the question should define the intervention, if any, that the patients are subjected to. Third is the comparison that will be done. Will the patients be compared to a control, a different treatment? Lastly is the outcome. By what metric will the patients be compared? Some add a fifth factor of time to include the amount of follow-up. This is implicit in some question but bears mentioning as the answer to the question might vary at different time points. From the research question flows the hypothesis you are reading or writing. Two standard forms of a hypothesis are the null hypothesis, as would be the case if there was no effect, or the alternative hypothesis, which can vary depending on research design. For experimental designs where everything is rigidly controlled, your hypothesis would be that X causes Y. For observational designs, you would hypothesize that X affects or is correlated with Y. The hypothesis can also imply directionality. For studies which attempt to show superiority, the hypothesis might be that X is greater than Y, whereas some studies you might want to show that X was different from Y. This would determine what form your power calculation would take and also how your statistics were designed and managed. In a specialized non-inferiority study, you may wish to show that one treatment is not inferior to another, and you might phrase your alternative hypothesis as such. Exposure and outcome. You may wish to show that adding radiation to these cute puppies would have an untoward result. How would this be done? Broadly in clinical research, there are two paths you can take. These paths are called directions of inquiry. In retrospective research, you begin with the cases, and typically you already know the outcome, so you can work your way backwards to the exposures to determine risk. Generally speaking, this will generate odds ratios. The interpretation of odds ratios as such may feel a bit strange. Interpretation would be odds of exposure given outcome. By way of quick example, if you were exploring the effects of smoking on lung cancer and you found that there was twice as many smokers that got lung cancer, your conclusion would be that patients with cancer were twice as likely to smoke, not that smoking causes twice the risk of lung cancer. In prospective research, you begin with a cohort of patients and follow them forward from some exposure or intervention. The outcome is recorded at set time points after. This will generate relative risks, which take the familiar form of risk of disease given risk factor. In the above example, a relative risk would allow you to say, a smoker has twice the risk of cancer as a non-smoker. Why does this matter? Let's explore a real-world result. This is an interesting study from 2010, a meta-analysis of total hip arthroplasty versus hemiarthoplasty for hip fracture patients who are elderly, the metric being reoperation. The format of the results is a forest plot. In a forest plot, the effect is indicated by the boxes and the variability is indicated by the whiskers. The diamond at the bottom of each column is the average of the studies, with the outer end of the diamond being the variability of that estimate. What these authors did is broke up the results of the study by design. For level 3 studies, or case controls, you can clearly see that the overall result is to the left, and as such, it favors hip arthroplasty. But there is a lot of variability. For level 2 studies, or poor quality randomized controlled trials, there's less variability, but it still favors total hip. For level 1 studies, there is very clearly no difference. How is this possible? There's only one truth, so how can these studies be wrong? Shouldn't a p-value of less than 0.05 establish causation? How can different levels of evidence show different results? The answer is bias and confounding. Higher levels of evidence incorporate more controls for bias and confounding. A simple example of this is that in prospective studies, follow-ups can be standardized to have less bias and variability in measurement. Randomized controlled trials can apportion different risk factors to different groups by random chance. This is going to be grossly oversimplified, but generally speaking, research can be broadly broken up into experimental and observational designs. Experimental designs are rigidly controlled for all confounding variables except the main variable of interest. As such, high-quality randomized controlled trials, basic science, and biomechanical studies fit into this category. Observational studies follow a group of patients, either prospectively or retrospectively, and control statistically later for confounders. They are vulnerable to bias and confounding. I include a third group here of scientific reviews, which include systematic reviews and meta-analyses. The quality of these are based on the quality of member studies. The level of evidence is equal to the lowest level of evidence of the member studies. The highest level of evidence is a meta-analysis of level 1 randomized controlled trials. The key question is, what is the best way to answer your research question? Prospective is not equal to retrospective. Prospective studies are long, they're expensive, they are labor intensive, but they provide high quality evidence and generally require simpler statistics because most of the confounding and bias have been weeded out. Retrospective studies are vulnerable to bias, confounding, and chance and provide low level of evidence and generally require more complex statistics to deal with bias and confounding. They are excellent for hypothesis generation for higher level studies. However, it is important to note that not all studies require higher level evidence. Consider this quote-unquote study from the BMJ, Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenge, a systematic review of randomized controlled trials. Not surprisingly, they found that no randomized controlled trials had been undertaken of parachute use. This is clearly a joke, but the moral is not. Not all questions require, warrant, or would even benefit from a randomized trial. So, how do you decide on a design for your study? Important factors to consider when picking a design are, number 1, how important is the question? Number 2, how many resources are available? Number 3, how much time is available? Number 4, what's the question and what's the best way to answer it? Number 5 is what would be most absorbable by the community at large? A common rubric for this is the finer criteria. Is the study feasible? And importantly, is the design feasible? Or are adequate resources available to perform the desired study or study design? Is the study interesting? Presumably the answer is yes, or the author would not do the study to begin with. Is the study novel? If the study is not novel, perhaps a higher level of evidence or a higher level of study is warranted to confirm earlier findings with lower level of evidence. Is the study ethical? The answer needs to be yes. The IRB can help with this. Is the study relevant? The study needs to pertain to current issues in order to be warranted. Possible designs for clinical studies include randomized controlled trials, prospective cohorts, retrospective cohorts, case control studies, case series, case studies, scientific reviews, ecologic studies, economic studies, and decision analyses. High level of evidence studies include prospective cohorts, generally level 2, and randomized controlled trials, generally level 1 or 2. Prospective cohorts are expensive and time consuming. They should be strongly considered if the exposure is rare and there is less selection and bias because the patients are selected at the point of exposure. Metrics and parameters can be set a priori, like instructions on how to measure range of motion or how to take a promise test or other outcome measure. A specific type of prospective cohort is a randomized controlled trial. This is an experimental version of a cohort study. Patients are randomized into a treatment, and blinding should theoretically take place. In surgical studies, it's easier to blind the rater of the outcome, as in single-blind studies, but harder to blind the patient or surgeon, as in double-blind studies. These are expensive and administratively heavy. Large amounts of funding are generally required. Mid-level of evidence studies consist of retrospective cohorts, which can be as high as level 2 or as low as level 4 level of evidence, and case control studies, which are generally level 3. Retrospective cohorts are less robust to bias than prospective studies. Outcomes are collected as part of clinical care, so their measurement is inherently variable and prone to bias. They are also vulnerable to missing data. Rare exposures can be assessed if the cohort is available. Case control studies compare patients with the outcome of interest directly to patients without. As such, it is good for rare outcomes. Can marginally increase the power of unbalanced designs where more controls are available. Low-level studies include case series level 4 and case studies level 5. Case series are uncontrolled and simply describe a series of patients that had a specific exposure, intervention, or procedure. Importantly, there is no evidence that patients' outcome would be any different if nothing had been done in the context of the study. Case studies are a series of 1 to 3 patients which are useful to report a rare outcome or clinical circumstance. They provide minimal evidence but can be helpful to describe management of a rare entity. Thank you. Please put questions in the comments.